Good morning, everybody. And sorry, I was a little bit late today. Believe it or not, I was on a meeting to do with clot retrieval and what money was required to extend clot retrieval across Brisbane and things, which is probably not unusual to have those conversations about funding and service needs. So we'll touch on some of that as we go through the section this morning. Melissa, can I just begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to elders past, present and emerging. I guess I've become alive even more so over the last couple of years to the needs of our First Nations communities. I have an adjoining office to Haylene Grogan in the department, and certainly one of my passions at the moment is to start to really work with Haylene to try and address some of the health inequities we've got out there in our First Nations communities and broader communities. So just really wanted to make that acknowledgement up front. I also want to say I have one of the best jobs in Queensland Health. And also one of the worst jobs in Queensland Health. So I have the privilege of deciding how to spend $16 billion with colleagues every year in terms of purchasing health services across our public hospital system, across our non-government organisations, and across our private healthcare providers. So it's an absolutely privilege to do the job. It can sometimes get a little bit challenging at times with some of the priorities we've got out there, but we can touch on some of that as we go through this morning's session. The thing that I probably will say up front in terms of my journey is I'm probably a reformed accountant. So I trained as an accountant. I was a finance director in my early 30s, and then suddenly realized there was more to life than numbers and accountancy and things like that. So my real passion at the moment for the last 20 years is actually using the position I've got to try and improve patient care and actually address some of the inequities we've got out there. That is the driving force for me. And hopefully I've instilled that in my team. That we're there to actually improve patient care. If we are doing things that isn't improving patient care, then we need to stop and rethink it. So there is a genuine desire there from me and from my division to actually focus all our efforts on improving patient care. That doesn't mean we can do everything. And I think that's the real trick in the job, is actually identifying those things which will add greatest value. And Melissa will talk about value as a concept a little bit, as I'm sure when we go through today, and what value means to different people. But actually trying to select those things which add greatest value and really starting to make sure that we invest in those things. So I've only got 2 or 3 slides. I was going to keep this really informal today. For those of you who know me, the conversation's the most important thing for me. Actually hearing your views and having some two-way dialogue. So I've got a few slides which I will quickly talk through, but then Melissa will probably just move quickly into questions if we can. So let me see. I've got my EA outside my office door because I am not known for my technical ability. Does that work? Melissa, can everybody see that?
Yeah, we can see.
Let me just start the slide show down there. Sorry, you'll gather IT is not one of my strong points. Can everybody see that? Yeah, okay. So look at just a couple of slides. The one thing I thought about last night was that whenever I try and explain what my division does, it gets awfully complicated. And Melissa, taking on board your comments about acronyms and all that type of wonderful stuff that I do really easily, I thought perhaps the easiest way to try and explain what we do in the division is to look at the commissioning cycle. And this is what the process that you will follow in your everyday lives around when you are looking to purchase things and actually buy goods and buy services. And it starts with strategic planning, moves into actually buying something, and then actually evaluating and monitoring what you get for what you purchase. And it's as simple as that, really. So if I just quickly go around the wheel, I'll try and bring it to life a little bit in terms of what we do. The dark blue between sort of 9 o'clock and 12 o'clock, one of the things that we don't do terribly well in health at the moment, but need to do more of, is actually understanding need in the system and actually understanding the healthcare services that our communities across Queensland actually need to be provided. And by provided, I'm probably broader than most people in Queensland Health. This to me is services that could be provided by a GP, could be provided by a community-based service, could be provided by a public hospital or a tertiary hospital. We have to understand need, and that isn't about the level of growth in demand for activity in public health services. It's actually really getting back to a lot of that demographic data and really trying to understand the needs of each of those individual communities. Are they going to need more elective surgery? Are they going to need more chronic disease? Do they need more prevention and things? So actually doing what I call a true needs assessment. And believe it or not, Queensland Health has just agreed that we will roll out and do a comprehensive local area needs assessment for every HHS across Queensland. And that needs to be done across all the primary healthcare networks as well. So I think, Melissa, if we're talking about consumer engagement and consumer involvement, the biggest thing that I think will drive our funding allocations over the next 5 years is the local area needs assessment that each of the HHSs will do. And they're forecast to do those between now and November 2021. So how consumers and communities engage in that local area needs assessment, I think is going to be really important over these next 12 months and is a real opportunity for consumers to influence the agenda. What we also have to understand as part of that is what services are currently being provided. So if you like, the straightforward gap analysis that I'm sure you're all aware of, we identify what the needs of the community are, we identify what the services that are currently being provided, and we've got gaps. We have gaps in service provision across Queensland, and the trick then is deciding on your priorities. Given the funding envelope that we have, how do you determine between a range of competing priorities which is the most important, and therefore the area that you actually invest your money in? So there's a lot of upfront work in terms of that dark blue segment of the diagram on there, which I think Queensland Health will spend a lot more time on over the next couple of years than it probably has done over the last 10 years. This is a personal view, but I think that whole planning environment needs some work, and that's certainly one of the areas that's within my remit as of about 6 months ago, is to actually improve the planning of services. What that's also going to involve is planning some of those tertiary statewide services, things like burns and transplants. And there's been obviously lots of conversations to do with renal disease, CKD, over the last couple of years, things like second renal transplant sites and things like that. So there's a full spectrum of planning in there, from both those really local services to the really high-end statewide complex burn services, transplants, and so on, where there is only probably 1 to 2 providers in the state. So that's the first sort of role of the division that I work within at this moment in time. The second sort of major jump there between sort of 1 o'clock and 5 o'clock is actually going out and buying those services from the relevant providers. So as I said at the beginning, we get about $16 billion at the start of the year. We need to work out what our priorities are, how much we need, what services we need to purchase, and where we need to purchase those from. So we do some fairly detailed work up front to determine how we're going to fund the services that we need to buy, and then we negotiate each year with every hospital and health service and most NGOs and most private providers the services that we want to buy for the residents of Queensland over the next 12 months. Ideally, we'd like to buy that for the next 3 years, and we'd actually like to give advance notice of what we're going to buy for those next 2 to 3 years. But given some of the funding uncertainty we've got at the moment post-COVID, that's quite a difficult one to do. So more likely annual negotiations that we have where we agree the funding that we're providing to each organisation. We're also the division that agrees what we're going to measure. So what's important and what is value. And again, that word value. So at the moment, we spend a lot of time measuring access to services, whether that be how long to get your hip and knee replacement, how long on an outpatient list, how long to get a scope. What we don't spend a lot of time doing is looking at what we would all call true outcomes. And that, Melissa, is I think where we've started the conversation. I'm not sure we've progressed that much. My own personal view again over the last 12 months, but how do we determine the outcomes that matter to the consumers who actually receive the service? How do we start to measure that? How do we get the feedback on what the patient experience? And we're starting to do more on that through Gillan Farmer's area around looking at outcomes, but we still have a long way to go, I think, in terms of really truly identifying what the outcomes are that we're trying to deliver. Once we have negotiated those contracts, the third bit of the jigsaw there is actually managing performance, which is the bit where I get a bad reputation because I am the person who has to hold all the HHSs to account for the delivery of performance across the state to make sure that we deliver the services in a timely fashion, in a high quality fashion across Queensland. So we meet with all the hospital and health services, we meet with all the NGOs and the private providers at least once a quarter to actually look at how services are being provided. We look to identify where we've got some pressures. Classic example was clearly the conversation I've come from this morning around clot retrieval, which is a clearly life-saving and value for money procedure, but how do we actually fund that in a sustainable way? So that's a real life example of only an hour this morning, how we can make that happen. There's a lot of things in that monitoring around patients and actually getting patients' views and patient experiences. I think we're not there yet on that one, if I'm perfectly honest, and we need to get better at that. All that basically then leads into starting the cycle again in the following financial year, really, to get ready. So we have to learn from what's happened in the previous 12 months and therefore start to tweak our plans for what we purchase in the following year. It's basically as simple as that. I can give you lots of jargon and things like that, but essentially we are trying to buy high quality, high value services for the residents of Queensland, and we're trying to make the dollars that we get provide the biggest value to the residents of Queensland. Okay, so it is fairly straightforward, but it is tricky because obviously the needs that we've got in the system far outweigh the funding that we've got, or the wants that we have from each of the. In terms of the structure that we've got, I'm not going to run through this in any great detail, but we structure that across the 4 areas that we've got. So from the right-hand side, system planning branch leads all the work around what we call those local area needs assessment in conjunction with the HHSs, and is really starting to do some work around those statewide services. The contracting and performance management branch has a twofold responsibility. They negotiate all the contracts with all our providers, and they actually do all the performance reporting for the state internally within the health system, so we can actually track our performance and identify areas where really we can improve the service. Healthcare funding and purchasing really looks at how we're going to fund services and how do we incentivize change in the system. We've tried using a range of financial levers and a range of other incentives. Sometimes they work, sometimes they don't. And I think that's a big question going forward about how we incentivize change. How do you incentivize the rollout of a best practice model across the whole of Queensland, which seems an easy thing to do, but is quite hard to actually get that statewide rollout. And then community services funding branch is essentially an area that looks at all the NGO contracts. Believe it or not, the team that we've got working on the community services funding branch is probably the biggest in that structure. So the spend on there is probably about $300 million compared to over 15 billion in the other parts, but that is probably about 250 individual contracts with non-government organisations who, I have to say, do a wonderful job. I think we keep the bureaucracy as low as we can. They make the money stretch as far as they possibly can. And I think some of the greatest value we've got in the system, and this is in those NGO contracts, when you look dollar for dollar at the value we get, I think those NGOs do a wonderful job. The other bit of my division that I'll just probably flag is the Office of Rural and Remote Health. I said in my opening gambit, one of the things I've spent the last 10 years in Queensland Health trying to introduce statewide plans. So I jointly led with John Wakefield the specialist outpatient strategy. I jointly led with John the work around the endoscopy action plan. I think what I've come to realise is that they have done a brilliant job improving access, let's say, for 90% of the Queensland population. What it hasn't addressed is some of the inequities we've got in there, both from a First Nations perspective, from a rural and remote perspective, and I think also from a mental health perspective. So really my focus over the next few years is to maintain the performance we've currently got, but I am really keen to start to tackle some of those inequities and start to tackle some of those problems that we've had in the system for a long period of time. Where that's going to morph into is consumer engagement. And I have to say, I think we've improved a lot with our consumer engagement. I don't think we're there yet. I think there are still times when we bring consumers in too late. I think there are probably meetings we bring consumers into that I'm not sure that that's appropriate as well. So I think we have to really try and define where the biggest impact can be from consumers and hearing some of those patient stories. And Martin, I'm going to embarrass you here with this next one. So I have never had, I think I came close in Stanthorpe last Thursday, but I've never had a consumer actually tell me what to do other than Martin, who I think said what I wanted to say. So we said we would invest in CKD through AKC 2026, which Martin is a member of. We had a group of clinicians. We were trying to work out what to prioritise, and you know those times where your criteria aren't delivering fully the answer that you think you want. I think Martin weighed in on an email one night. I remember getting the email from Martin and said, look, we've got to do this Western Cape model. It's a no-brainer. It's a major requirement up there. And I think it sort of galvanised me to go back to the clinicians and say, look, I know it doesn't really fit with the criteria, but it's the right thing to do, guys. And you can see some of the results on there. Not much money in the overall scheme of things, but the impact it's had on access and community there, I think, has been phenomenal. So when it works really well, consumer engagement, it works exceptionally well. And I think AKC 2026 is a great example of that. I think we're starting to see that in my area through rural and remote as well. I think Jim and Joe, we heard some real what's the word I'm after? Concerning stories when we were in Stanthorpe last Thursday, which were a real eye-opener to me, because I thought we'd done a pretty good job investing in drought and things like that, but it turns out we hadn't. And we'd essentially got a community that wanted to take part but didn't feel able to with government, and basically collaborated together to try and do some really good things. So I think for me, it's a matter of trying to define more closely where and when consumers should be engaged with consumers and actually utilising those patient experiences. There is nothing like a patient experience and a patient story to try and galvanise me, the division, and I think the broader department about where we should look and where we've got some inequities. Melissa, there's probably hundreds of other things I can talk about, but if I'm honest, what I enjoy is actually working with consumers and clinicians to invest in a model of care where you can actually see an outcome and you can actually see patients and you see the feedback from patients, and you actually, I think that's what keeps us going. And certainly in my division, doing a spreadsheet and sitting in the office isn't a turn on for me, and I don't think it's a turn on for my division. But understanding where we can make a difference is, I think, what is the real focus for us. The trick is deciding on what you can invest in and what you can't, and that comes full circle to the value question, which I think we'll talk about over the next hour. So I haven't done any more than that, Melissa, because I would much rather hear from consumers and have the dialogue if I can. So I might leave it there, and I will attempt to stop sharing the screen, and then happy to take 1,000,001 questions about work or private. I'll happily do either one today.
Excellent. All right. Well, look, thank you so much, Nick. That's really helpful, I think, for all of us really to have that clarity, especially with some recent changes that have happened with the structure of the department. It's really helpful to understand that. And I guess some context around this is the envelope of funding that we currently have. And Dan Kent asked a question about how does the current $16 billion pot of health funding administered compare to that of, say, 5 years ago, and what's on the horizon?
So look, I guess a couple of comments on that. One, I think the funding to the state, I've not got the exact numbers, but I think in general we've done reasonably well over the last 10 years. I came for good to Queensland back in 2010, and I think we've seen year on year good growth, both from state and Commonwealth. I think it's dropped off a little bit over the last 2 to 3 years. And I don't think, Dan, this would come as a surprise. I think when you look at the forward outlook, given COVID, given the way the economies worldwide are struggling, there's no doubt we're looking at much lower levels of growth going forward. The one thing I would say is, and I keep couching all these as personal views because I haven't checked these out with John whether they're corporate views, but most of the time we have conversations about what we do with growth money. I still think we need to have some more conversations about the value that we're getting from the current $16 billion that we've got out there. And I must be honest, I don't think we do that well at the moment. We have lots of conversations about the growth, which in the overall scheme of things, we probably have, let's say, $200 to $250 million worth of growth per annum. And that's got to fund growth in emergency departments, elective surgery, endoscopy, and so on. Relative to the existing funding, it's a drop in the ocean. So I think we've got to do more to look at value. I think that's where some of the consumer angles come in, because I think if the department was to say, we're going to stop doing this service so we can invest in this service and we believe it's higher value, hearing that from a bureaucrat is not the best thing, whereas actually understanding and having some of those conversations with consumers, I think, is a really positive step forward. But we haven't done that today.